Section 7. Defining public health. What is the true measure of success for a society? What is it that makes us happy, healthy, stable, and in balance with the world around us? Is not our success really our ability to understand and adapt to the realities of our world for the best possible outcome for any given circumstance? What if we were to realize that the very nature of our social system was actually reducing and suppressing our quality of life? Well, it does seem pretty apparent that modern social structures, values, and practices have deviated away from or are largely ignorant of what true public health actually means. What our social institutions today give priority to or discount by design, coupled with the goals and motivations associated with personal success, which are all too often clearly decoupled from true life support and advancement, is a subject given little thoughtful consideration today. In fact, most prosperity and integrity measures for the human condition are now haphazardly equated to mere economic baselines such as the gross domestic product or the producer price index, or employment figures. Sadly, these measures tell us virtually nothing about true human well-being and prosperity. The term public health is a medical classification, which is essentially defined as an approach to medicine that is concerned with the health of the community as a whole. While this is often used in relationship to transmittable disease and related social conditions, the context here will extend to all aspects of our lives, including not only physiological health, but mental health as well. If the value of a social system is measured by the health of its citizens over time, assessing and comparing conditions and consequences through simple trend analysis and factor accounting should give insight into what can be changed and improved on the social level. Since each respective component of public health has its own characteristics and causality, we can also work to consider alternative approaches to a given method of problem resolution or improvement, which might not currently be in practice, but clearly should be. An analysis of current public health components to understand what is happening over time in different circumstances, coupled with a per-case evaluation of each issue with an inferential consideration of what could fix or improve these results on the largest scale possible, is the basis for the train of thought expressed here. It is the conviction of the Zeitgeist movement that the existing social model is the cause of social pathology, with a perpetuation of imbalance that is unnecessarily generating physiological and psychological disorders across the population, not to mention limiting human potential and problem resolution in many ways. Of course, this context also naturally extends to environmental health, meaning the state of the planet. As such, ecological problems always have an effect on our public health in the long term. Let it be well understood that physiological and psychological outcomes rarely, if ever, have singular causes. There is a biopsychosocial relationship to virtually all human phenomena, illuminating once again the multi-level symbiosis characteristic of the human being. In other words, while the problem being focused on might be considered physiological, in general the underlying cause might very well be psychological or sociological, and vice versa. Section 7, Part 2. The economic factor in public health. If you take a quick glance at the major causes of death globally, as put forward by the World Health Organization, there are clear differences based on the economic state of a region, such as the fact that cancers are more common in high-income societies, while diarrheal diseases are more common in low-income societies. This gives us insight as to how the broad context of socioeconomic position can affect public health. Mahatma Gandhi once said, "Poverty is the worst form of violence." His context relates to the unnecessary deaths caused by poverty in the sense of the broad limitations such severe financial restrictions have on health. This idea was later encompassed into a term called structural violence, defined by Dr. James Gilligan as the increased rates of death and disability suffered by those who occupy the bottom rungs of society. He differentiates between structural violence and behavioral violence, where the former operates continuously and slowly, rather than quickly and sporadically. Please note that the term violence in this context is not limited to the usual classification of physical harm, such as person-to-person combat or abuse. This context includes the often unseen social oppression that, through the chain of causality characteristics inherent in our social system, leads to the unnecessary harm of people, both physically and psychologically, or both. Examples of this can range from obvious to complex within the chain of cause and effect. A simple macro example would be the prevalence of diarrheal diseases in poverty-stricken areas. These diseases kill about 1.5 million children every year. It is completely preventable and treatable, and while the infection itself is spread through contaminated food and drinking water or from person-to-person contact as a result of poor hygiene, its very preventability and rarity in first world nations by comparison shows that the real cause is not the disease itself, but the poverty conditions that enable it to flourish unabated. However, the causality does not stop there, as we then need to ask the question, what is causing the poverty? A more abstract micro-example would be human development problems that arise when pressures in family or community structures occur. Imagine a single mother who, due to a financial situation, needs to work 2 jobs in order to make ends meet, limiting her availability for her child. The pressures not only reduce needed support and guidance for the child's development, she also begins to develop tendencies for anxiety and depression due to ongoing stress of debt and bills and the like. And then frustration-driven abuse begins to take place in the family. This causes severe emotional loss in the child and the development of neurotic, unhealthy mental states, such as the propensity to do drugs later in life. Still suffering from the pain felt in those early years, the now adult child dies of a heroin overdose. Question: what caused the overdose? The heroin? The mother's influence? Or the economic circumstances the mother found herself in, which disallowed more balanced and thoughtful care of her child? Now, you may want to blame the mother or the child for the parts that they played in this, but it is a statistical fact that when you average out large groups of people, this happens much less often in better economic conditions. So, assigning blame doesn't prevent this from happening, but providing better economic conditions clearly and provably can prevent this from happening. Clearly, there is no utopia for the human condition, and to think we can adjust the socioeconomic system to thwart all such structurally related issues, macro and micro, 100% of the time, is absurd. However, what is possible is a dramatic improvement in such public health problems by shifting the nature of the socioeconomic condition in the most strategic way that we can. As we proceed with the per-case analysis of major mental and physical disorders in the world, it will be found that the true imperative for public health improvements rests almost entirely on this socioeconomic premise of causality. According to Gernot Kohler and Norman Alcock in their 1976 work An Empirical Table of Structural Violence, a dramatic 18 million deaths were extrapolated to occur each year due to structural violence. And that study was over 30 years ago. Since then, the global gap between the rich and the poor has more than doubled, suggesting that now the death toll is even much higher today. In effect, structural violence is the most deadly killer on the planet. The following chart shows rates of death of a specific demographic, revealing the more broad correlation between low income and increased mortality. Section 7, Part 3, Physiological Health. The core physiological problems of the human population today include major mortality-producing epidemics such as cancer, heart disease, stroke, etc., and more minor problems like high blood pressure, obesity, and other issues which, while less critical by comparison, are still usually part of the process that can lead to major illnesses and deaths over time. Again, it is important to remember that the causality of these physical diseases is not strictly physical in the narrow sense of the word, as modern study has found deep psychological connections that are provably linked to these physiological issues. According to the World Health Organization, the most common causes of death shared in low, middle, and high-income countries are heart disease, lower respiratory infections, stroke, and cancer. While each of these illnesses and many more can be found related to the causal points that follow, for simplicity's sake, I'm going to focus on heart disease. While the treatment of heart disease has led to a mild global decline in heart attacks and deaths overall, the diagnosis of heart disease has not subsided, and coronary heart disease is still considered to be the leading cause of death globally by the World Health Organization. It has been found that while there are genetic factors at play, 90% of those dying have lifestyle risk factors, and overall the disease is widely considered preventable if lifestyle adjustments are made. In short, well-established relationships to high-fat diet, smoking, alcohol, obesity, high cholesterol, diabetes, and other risk factors allow us to extend the causality of heart disease. The most broad and profound risk factor had to do with not only absolute income, but relative socioeconomic status. The World Health Organization makes it generally clear that on the global scale, lower socioeconomic status breeds more heart disease and naturally more of the risk factors that lead to it. This depicts a direct economic relationship to the occurrence of heart disease. There is no evidence to show that genetic differences between regional groups could be responsible for these variations, and it is obvious to see how a lack of purchasing power leads people into the lifestyles that include many of these risk factors. A 2009 study in the American Journal of Epidemiology, which was called Life Course Socioeconomic Position and Incidence of Coronary Heart Disease, found that the longer a person remains in poverty, the more likely he or she is to develop heart disease. People who were economically disadvantaged throughout their lives were more likely to smoke, to be obese, to have poor diets, and the like. An earlier study by epidemiologist Dr. Ralph R. Farichis, focusing on specifically the socioeconomic divide in Los Angeles, California, found that the death rates from heart disease was over 40% higher in poorer men as opposed to wealthier men. Given our original thesis to consider a link from the socioeconomic system itself to the prevalence of diseases and their associated risk factors, we need to consider the direct relationship of stress and purchasing power, beginning with the latter, which is more simple. Clearly, poor dietary habits occur in lower income environments due to the lack of funds, and this could also be said for medical attention and education. Many of the high-fat, high-sodium risk factor foods, for example, that lead to heart disease are also the most inexpensive. It is worth noting that our socioeconomic system produces goods based on the purchasing power of targeted demographics. The decision to produce low-quality food is made in the interest of profit, since the vast majority of the planet's population is relatively poor. It is no surprise then that in order to sell to that market, quality must be reduced in order to allow for competitive buying. In other words, there is a market for each social class, and naturally the lower the class, the lower the quality. This reality is an example of a direct social system link to the causality of diseases. While education about the differences of food products could help the decision of a poorer person to eat better, the financial restrictions inherent to their condition could easily make that decision difficult, if not impossible. Not to mention the lower quality of education that poorer people have access to in most cases. In an age where food production and human nutrition is well understood as a scientific phenomenon as far as what works and what doesn't work, and what is healthy and what is not healthy, we have to wonder why so much of the food we produce is unhealthy. The reasoning is that human health is not the pursuit of industrial food production. Instead, we simply have the isolated interest to generate income.